Good morning, good afternoon, and good evening. My name's Edward Kelly. I'm Director for Integrated Health Services here at the World Health Organization, located in Geneva, in Switzerland. And it's a real pleasure to be able to join you today. Our longstanding connection with Korea and with HERA is being carried forward with work that we'll be taking together on health services assessments, and we've had an exchange of staff, and my own personal pleasure at being asked to speak to you today, and with the connections that I have with your leadership and with the Korean government are very strong. My only regret is that I'm not able, because of the current outbreak, to easily get on a plane and join you in Seoul, Korea, but I'm looking forward to the next meeting that you have on this topic and to joining you just as soon as possible, but certainly to continuing our work together on the many common areas of interest. And today, I've been asked to speak to you a bit about the impact of the current outbreak, COVID-19 outbreak, on universal health coverage, especially the issue of maintaining essential health services during the pandemic. I'll try to go through in just a few minutes some of the background and framing for the situation, of which you're well aware. The issue of COVID and its work and impact for countries all around the world has been really quite important and amazing, that we see a rise of cases and certainly a rise of deaths earlier in the year, but now a current plateauing of both the outbreak and in terms of cases, and also globally across the world in terms of deaths. But last week, a week ago of October 5th, which now will be a bit dated once this comes to you, was our biggest week since the start of the outbreak, and there's certainly indications that in the Northern Hemisphere things will start to rise as we move into the winter seasons and the flu. We can see clearly that while there's a wide range of situations across countries of deaths reported per million population, that the amount of time in that bottom right graph, where the days to reach each million cases, and then next to it, the days to reach each 100,000 deaths, has also plateaued. As you can see, it took us to go from 2 million to 3 million, took us somewhere between around 12 days, 14 days, and now we're moving at a pace of 3 days to reach each of those new cases. Our Director General has stated that there is no health security without resilient health systems, and that the outbreak has clearly put this in stark relief. The best defense, as he said, against any outbreak is a strong health system, and it's really revealed not perhaps the only system that it has revealed weaknesses, but it's certainly shown the fragility of our world's health systems and the areas that we perhaps have underinvested and under-supported over the recent past. And I'll speak briefly about that. Some of the health system challenges that we've seen during the COVID-19 outbreak are a huge stress posed by the large number of patients with COVID-19, obviously. The lack of supplies and equipment, particularly around personal protective equipment, but many other health products also. The burden on healthcare workers who are being asked to surge to take care of COVID patients, but then also to carry out essential services, and the big disruptions in essential health services. So we are literally living through the dual demand being placed on our health systems of having to respond to an outbreak, a global outbreak, and also having to maintain essential health services so that people do not die from unintended consequences of COVID. So we need to put this, I think, in the context of where we were before this outbreak started. We were working on the overall goal framework of the Sustainable Development Goals, and certainly within health, that focuses on universal health coverage. Within that, and as the high point of 2018, we had the Astana conference, where the Declaration of Astana reiterated our commitment to primary healthcare as a pathway and an approach for the achievement of the Sustainable Development Goals, and in particular UHC. There were three components of PHC, which were all three relevant to the issues now presented by COVID-19 of preparedness, response, and recovery. Firstly, that primary healthcare and essential public health functions need to be at the core of any country's health system. It needs to be supported. Those services need to be supported by multiple sectors and need to be serving empowered people and communities. Now, in terms of universal health coverage and the agenda there, it's quite clear that, again, COVID-19 is a bright light shining in through the cracks that exist in our system for universal health coverage, where patients being hospitalized for COVID are facing big hospitalization costs. Access to testing and to primary healthcare testing and services also is limited for many populations. And these types of issues are ones that we can start to address and unpack together. In 2019, at the UN General Assembly, we looked as a follow-up to the Astana conference at universal health coverage, with a high-level event at the UN General Assembly. And we published, I was one of the authors on it, of the UHC monitoring report, looking at the impact and progress on universal health coverage. So about 200 billion a year of additional investment is needed in primary healthcare if we're going to reach universal health coverage. This was one of our conclusions from that monitoring report in terms of what we're investing now and what's needed. And some of the general approaches to achieve increased primary healthcare spending by country income group were enumerated in that report, with different approaches more relevant for different country settings and different country contexts. Certainly, there were a number of bottlenecks highlighted in that meeting and since, as we started to move more quickly on the universal health coverage agenda. It's quite clear that we do have different interventions and interactions that are known to work, but that need to be scaled up. We have major barriers that still exist in service capacity and certainly in access. But for the first time, we talked about in that report the issues of quality of care and of trust that are clearly existing. And as someone who served on the Lancet Commission for Quality Health Systems, this is one of those gaps that even in WHO, we have not done a good enough job of addressing over the years. We have often made universal health coverage, because of the early work on financing, as a financing question, when really it's a question of both finance and service delivery reform being brought together to focus on a primary healthcare approach. And looking at that primary healthcare trajectory, emphasizing prevention and promotion, ensuring equity of access to essential interventions, and limiting out-of-pocket spending on medicines is going to be key to achieving what we need to on universal health coverage. Now, scaling up primary healthcare interventions across low and middle income countries could help save 60 million lives and increase an average life expectancy by 3.7 years by 2030. And a full UHC package could save 100 million lives. These are some of the findings of this report that you see on 2019. But countries are at very different stages in their service coverage and financial protection. You can see in this graph that looks at the service coverage index. So this is the UHC index that we've tracked over the years and has been agreed by the UN Statistical Agency as most appropriate for tracking universal health coverage. And then along the x-axis, the incidence of catastrophic spending. So this is really an access and finance question. You have different countries in different situations where some countries are paying a lot, but they've been able to achieve a certain level of UHC. You have countries not paying enough and also doing quite a good job on achieving universal health coverage. And then you have countries that are both unable to pay enough and also not reaching their goals. And these in quadrant 4 are one of the ones that we need to address the most. And each of these shows that there are different, again, solutions and different priorities for us. And you can see also that many of these fragile states that we work with are in the lower end of the spectrum in terms of achieving UHC. The proportion of population that lives within 5 kilometers of a health facility is very associated with the coverage of health services. This is something that's being shown more and more as being relevant for this particular outbreak, but it continues to be relevant for universal health coverage. And this is something that's relevant for many countries in our Africa region, but also for my own country in the United States, with big, vast gaps of service coverage in certain rural areas. This has big political consequences as well as big health consequences. We also showed that universal health coverage is tied to health worker density. Clearly, the foundation of strong UHC and of high quality service delivery is the health workforce. And if you look at countries looking at the UHC index and also the density of health workers per population, you can see a very precipitous relationship in both the index and in the value of the SCI. However, some countries have done a good job in looking at other strategies for achieving universal health coverage. So outreach interventions, they can help improve coverage and can help improve equity. This is an important lesson also for pandemic response questions, where you need to reach out to people and meet them in the communities where they are. But they don't fully eliminate the barriers to equity. You can see that that in general, first doses and all doses being received on time are a big difference if you're looking, for instance, at immunization. So outreach can get you some of the services you want, but if you're really looking at full integrated health service delivery, even within immunization, it's difficult to make that happen. Trained health providers can also make a big difference. And study from the service availability and readiness assessments from 6 countries in the Africa region shows that that in terms of the percentage of facilities offering any antenatal care services, or whether staff have received any antenatal care training in the past 2 years, you can see on the left and on the right, providers in the facility able to diagnose and manage diabetes in patients, and then having received any training in the diagnosis of diabetes in the last 2 years. Clearly, there are big gaps in terms of the staff being trained to do the services that are supposed to be provided in those facilities, which is the gap between the gray bars and the red bars here. Equipment and also the delivery of services were big conclusions we looked at in terms of quality of care. There are big gaps in terms of the availability of equipment and the staff that's been trained in it in terms of antenatal care services. That's the gap that you see across those countries on the left-hand side in terms of percent facilities that have those. And also there are big gaps in terms of the use and delivery of the services. So for the percent of women who had a live birth in the last 5 years, we looked at the demographic and health surveys, looked across 34 countries, and found that we had somewhat high, above 80% coverage for women who had at least one antenatal care visit. The number who had all 4 dropped precipitously down, in some cases to almost half. And then the number who had those 4 visits plus had the additional measurements that they were supposed to have around blood pressure, tetanus, vaccines, dropped even more, to less than half of what the number of women that had received those first services. So there's a big continuity and integrated element that is not happening. So what do we know then about access and quality of health services related to COVID? Well, already I've told you that the Lancet Commission had concluded a number of things related to poor quality, but that 8.6 million deaths per year in low and middle income countries were due to inadequate access to quality care. So more people die from poor quality care than die from lack of access to care. Yet we often talk only about access. there's a big likely increase in the deaths related to both access and quality in terms of the COVID pandemic, and we need to consider these together. WHO has had a number of responses to COVID in general. We've been working on research and development with a big meeting in January of this past year before travel was not possible anymore. And there's been a major set of research trials, both for vaccines as well as for therapeutics, and also looking at the diagnostics and laboratory capacity. We've also worked with countries to prepare and respond, both in terms of helping develop response plans, helping with the networks and help desks and learning platforms and guidance. We've also helped coordinate the global response through our partner platform and facilitated a major procurement of essential medical products, which is still going on today, where WHO was put in charge by the Secretary General of the UN of the UN's big supply chain mechanism. And that was for personal protective equipment, but it's also been on ventilators, and it will soon be more on therapeutics, diagnostics, and eventually working with partners such as UNICEF on the vaccine distribution. We've also been working very hard on the infodemic side of the epidemic, or the pandemic, which is the communication about how people can protect themselves and others, and what they should learn about the truth and the non-truths that are out there related to the pandemic. The next step for WHO, as it continues its response, is to be an active member of the ACT Accelerator, the Access to COVID Tools Accelerator. This is a global collaboration to accelerate the development, production, and equitable access to COVID-19 tests, treatments, and vaccines. And on the slide, you can see the different pillars which have to do with vaccines, therapeutics, and diagnostics. And the idea of the ACT Accelerator, as someone who worked very much at WHO during the H1N1 outbreak, during the Ebola outbreak, was that as, for instance, during H1N1, a vaccine became available, there was a big rush by countries with the means to do so to buy up doses of the vaccine, leaving much of the world behind in this. And as we have seen from the questions about travel, if any country is left behind, all countries will be left behind in this particular outbreak. So there's work on coordination and support, access and allocation, as well as norms, standards, regulatory work, and policy guidance. And our work within my team has been to advance the health systems connector, as you can see in the upper right-hand corner there, that looks at how we can ready health systems to receive these new tools and to bring them into clinical practice as quickly as possible. Below is the current overall ask, which is $38 billion, which seems like a big amount, but not when you consider the amount countries are spending on their economic recovery in light of this outbreak, which is many, many, many times that ask. And we're currently, the work to try and raise this funding is ongoing, and with work with many different partners that you can see above. There also is the connection of the ACT Accelerator with a wider work of several other frameworks. Firstly, there's WHO's SPRP, as it's called, the Strategic Preparedness and Response Plan that guides our work. And you can see on the left-hand side there, the different pillars of the work, from country level coordination all the way down to the bottom level. They're the 9th pillar, which is the pillar I'm in charge of on the continuity of essential health services and systems. There is also the Global Humanitarian Response Plan, which is the response plan across the different humanitarian partners, WHO included, that covers these areas as well. And there is the UN framework for the socioeconomic response to COVID-19. And this is a framework requested by the Secretary General, developed earlier in the year, and which takes a, quote, health first approach, pillar 1 of that framework, which also talks about social protection, also talks about the economic response and macroeconomic response and multilateral collaboration, as well as community resilience and social cohesion. It takes that health first approach, which builds on the essential health services continuity. And our job here has been to make the connections between all of these and make them work in an effective way. The heart of that type of work is related to the guidance that we came out with earlier this year on maintaining essential services, which is an operational guidance for the COVID-19 context. There are 3 parts to it, and I'll highlight a few key conclusions from it. First is a set of operational strategies around maintaining essential services. The second part goes into the specifics about how do you adjust health services to safely deliver care during a COVID outbreak in 4 different specific disease areas and 4 different specific populations. And then finally, we finish with some sample indicators that have since been developed into a more advanced data strategy for COVID and for the response and the resilience and building back better that I'll highlight briefly before I close. Here are some of the basic principles and practical recommendations that are taken forward in the first portion of this that have to do with the ensuring timely access to emergency care services, coming up with a priority essential services list, reassigning health workers, and looking at how you maintain essential medicines, equipment, and other foundational elements needed to deliver safe care. But we also looked at and made strong recommendations about removing financial barriers to access at the point of care, to suspend user fees, something that's been extremely important for many countries to ensure that patients are able to access care even in situations where they may not be immediately able to pay out of pocket. But there's also information that's needed in local languages, and shifting the delivery to consider other delivery platforms. And I know that Korea and other places have been very strong on accelerating their use of digital health tools to try and ensure the continuity of essential services. We've come also looking with a survey to a wide range of countries where we received 124 responses in terms of countries across the globe between May and August 2020 to look at what the interruptions have been to essential health services. And I'd encourage you to look at the interim report, which is on the website. But 68% of countries had defined some essential services that were made to be maintained during the COVID-19 pandemic. And this is the first big step to do so in terms of looking at how your national service package is adjusted for essential services and what need to be maintained. But much fewer countries had actually set aside special funding for maintaining those services. And given that there are in many cases considerable extra time and extra resources to deliver services safely, this in some cases it's quite worrying. But overall, across 25 tracer conditions, we found big interruptions. So I think the bottom line story in this slide, you see the percentage of countries who are reporting disruptions in these different service areas. The 2 points to take away: one, everything from routine immunization and NCD diagnosis and treatment, all the way to even emergency surgery and 24-hour emergency room services, something that we would hope would almost never be interrupted, were impacted by the COVID-19 pandemic. And overall, across the world, about 50% of health services at one point were either partially or severely disrupted. In terms of the reasons for those service disruptions, this is very interesting. Of course, there were issues, as you can see down the left-hand side there, of insufficient personal protective equipment. Of course, there were issues of changes in treatment policies or perhaps even financial difficulties, but other issues like government and public transport lockdowns had even bigger impact. And the number one reason why services were paused or interrupted was that people were not coming. You can see the decrease in outpatient volume due to patients not presenting was the top reason why services were interrupted across the world. And I think this is something that we should also consider. Lack of trust in health services did not start with COVID-19. There is in many parts of the world, at least where I have worked, some worry and skepticism about the safe delivery of services in an outbreak like this, which taps into concerns that we have about safe care, about patient safety, and about infection prevention in our health service delivery sites. Other guidance and tools that WHO has made available have to do with the maintenance of essential services. We have tools around hospital readiness tools around the tracking and use of biomedical equipment for COVID-19 case management, surge calculators for forecasting supplies, as well as forecasting health workforce requirements. We've got guidance on community-based healthcare, which would be so when health workers need to leave the facility and go out to outreach and campaigns, how can it be done safely? And also recent guidance on preventing and managing COVID-19 across long-term care services, an important policy brief and tools that have come there. We've got educational platforms that we have been advancing, the WHO Academy, which is a new initiative being started by WHO to centralize our training work and education work. Has a new COVID-19 app, and with it, there's also an open WHO online course on this. So I just conclude with thanks to the organizers for the invitation with a couple of points. First, it's quite clear that governments need to rapidly scale up their investments in core common goods for health. Now, these types of common goods, as we call them, are what will drive our work towards towards universal health coverage, but also support at the same time our ability to react to this pandemic and respond to it, as well as prepare for the next pandemic. This includes commitment to the international health regulations. It includes commitment to primary health care and universal health coverage. Countries also need to maintain the continuity of the provision of essential health services during the COVID-19 response. It is from all forecasting, there will be major morbidity and major mortality impacts, not only from COVID, but from what people are suffering from in the wake of COVID, while health systems are responding to the pandemic. Failing to do so will put a strain on already stretched health systems, and we need to be able to look back on this outbreak and realize that we were able to minimize that impact. Countries also, they need to remove as much as possible the financial barriers to accessing health services, and governments need to be able to establish reliable mechanisms, to ensure that delivery of essential health services is not restrained by fee services or by financial barriers. This is the message of universal health coverage, but it should be the message right now around this pandemic. I thank you and I thank the organizers for this opportunity to be virtually with you. I wish you all to be staying very safe, and that means both staying physically safe as well as staying mentally safe. These days with our crazy work schedules, the demands, particularly for health professionals like yourself and myself, it's very challenging. But just remember that WHO is with you in spirit and looks forward to the opportunity to interact and support the mission of HERA and our common mission together for health and security of the world's population. Thank you very much.